Hi, my name is Dr. Natalie Riblet, and I'm going to be hosting the BIC training program today. So this training session will cover the delivery of the long-term regular BIC follow-up contacts by trained volunteers. So the agenda is I'm going to review the key elements of the BIC program, provide an overview of the long-term regular BIC follow-up contacts by trained volunteers, provide some guidelines on how to deliver the follow-up contacts, and then share with you some general tips and advice based on our prior experiences with the intervention. So the Brief Intervention and Contact Program, or BIC, the three goals are really to enhance engagement, to build a patient's sense of self-efficacy, and to increase their social support and connectedness. And the BIC program achieves this goal through three key elements. So one is education on suicide risk, incorporating motivational interviewing techniques, and providing the patient with structured support for 18 months after discharge. And in terms of staffing, so the professionals are responsible for delivering the brief motivational intervention, and then the long-term regular BIC follow-up contacts are delivered by trained volunteers. And the BIC program, the first piece, so the brief motivational intervention, that occurs either in the emergency or hospital room setting, and the follow-up visits can either occur by phone, through in-person physical visits, by messaging, or through telemedicine. And so in terms of the timing, the long-term regular BIC follow-up contacts, they occur at 1 week, 2 weeks, 4 weeks, 8 weeks, 12 weeks, 4 months, 6 months, 12 months, and 18 months after discharge. The objectives of the follow-up contacts are to monitor the patient's symptoms since discharge, to assess their adherence with post-discharge care, to review their safety plan, and if necessary, to help them with engaging in care. And I recognize that you are all trained volunteers and will probably already know not to do this, but I think nonetheless it's really important to emphasize that it's important to avoid in the contacts a pattern of questioning that doesn't allow the patient to ask questions or only elicits short answers from the patients. It's also important to avoid conveying to the patient the false impression that you have all the answers to every problem. And of course, you want to avoid blaming the patient for their situation. So motivational interviewing is one technique that the BIC draws upon when inviting patients to explore and resolve their ambivalence around making behavioral changes to address their suicide risk. And so this technique, which was developed by Rolnick and Miller, can be especially useful when patients are highly ambivalent to change, when they have low confidence about their ability to change, when they have a low desire to change, and when they feel that there is a low importance to making a change. And as I mentioned earlier, motivational interviewing was originally developed by Miller and Rolnick, and they updated the approach to the technique in 2013 to highlight the following features that practitioners should really emphasize when delivering the motivational interviewing skills. So one is a concept of partnership, evocation, acceptance, and compassion. And they also highlight that there are 4 fundamental processes that inform motivational interviewing, which is engaging, focusing, evoking, and planning. And we're going to talk a little bit more about this moving forward. So some common motivational interviewing interaction styles are the use of open-ended questions, so really allowing for a back and forth between the patient and the provider. Affirmations, so really affirming when the patient has made progress, reflecting back to the patient what you're hearing that the patient is telling you, attending to the language of change, so noticing when a patient seems to be making progress towards making a healthy change, and then also exchanging information with the patient that can help them in terms of making choices that are in support of their health and well-being. So when we talk about empathy, and expressing empathy, I thought the best way to help you understand these concepts is to provide you with some examples. So let's say that the patient says to you, "It's been overwhelming since I've been home. I want to get better, but I don't even know where to begin." So you as the interventionist might respond to the patient, "So you really want to start feeling better, but it's overwhelming because you're just not sure where to start." So you're really trying as best as you can to empathize with the patient about their current struggles and situation. Another important piece also is to help to begin for the patient to develop a sense of discrepancy when what they may want to do stands in opposition to what they may feel like they're capable of doing. And so, for example, here, if the patient says, "My medications do help me with my anxiety and my mood, but I don't always want to take them," you as the interventionist might respond to the patient by saying, "So sometimes you don't feel like taking your medications, but taking your medications helps you better manage your anxiety and your mood." So you're beginning to help the patient sort of themselves see where there may be some discrepancies between some of their desires and some of their actions, and how that might be getting in the way of them achieving their ultimate goal of achieving good health. Another piece that you will definitely probably encounter with a patient is they might be resistant to making certain changes. And so in this case, it's really important to not try to fight the patient, but instead use this principle of rolling with resistance. And there are several strategies that you can use to do this. And these strategies include simple reflections, amplified reflections, double-sided reflections, shifting focus, so moving the topic to something else, agreement with a twist, or reframing. So simplified reflections, so for example, that might be the patient says, "I don't plan to see my doctor anymore." And you as the interventionist might just reflect exactly back to the patient what you just heard. You don't think that seeing your doctor will work for you right now. An amplified reflection is where you're putting a little bit more, you're reflecting back, but with a little bit more oomph. So the patient might say, "I don't plan to see my doctor anymore." And you might say, "You don't think that seeing your doctor will work for you right now because you don't think that it's necessary." So you're basically, again, just mirroring back to the patient what they said, but with a little bit more amplification. And again, with the goal that sort of the patient begins to hear from within themselves what they might be struggling with. A double-sided reflection. So this would be, for example, if the patient said, "I know you want me to keep seeing my mental health doctor, but I'm not doing it." So you might respond by saying, "You can see that there are some important issues here, but you're not willing to think about keeping all your appointments with your doctor." So in this case, you are reflecting back to the patient what they're saying, but you're giving some interpretation also with it as you reflect it back to them. Shifting focus. So if the patient said, "I know you want me to keep all of my appointments with my therapist, but I don't always have the time to do it because of work." So you might respond by saying, "You're a bit ahead of me. Let's first explore your concerns about whether you can make it to some of your appointments with your therapist. We're not quite yet at the point to talk about whether it will work for you to keep all of your appointments." So in this case, you're trying to shift the focus a little bit and maybe narrow it down so that the patient doesn't start to get caught up in too many different reasons why they can't do a particular action. Agreement with a twist. So if the patient says, "Why are you so focused on my risk of being suicidal again? I'm just glad that I don't feel that way right now. Wouldn't you feel the same way?" And so you as the interventionist might respond by saying, "You have a good point. There's a bigger picture here, and maybe I haven't been paying enough attention to that. It's not easy to try to think about the possibility that your suicidal thoughts could return again, and keep in mind that you're feeling much better right now." So you're agreeing with them, but there's a little bit of a twist in terms of how you're agreeing with them and sort of pulling it back and not necessarily engaging directly in their statement about, wouldn't you feel the same way? So reframing, so the patient might say, my friend is really mad at me that I struggle with suicidal thoughts. She keeps saying, what more can I do to help you? But tell you that I'm here for you. And you, as an interventionist, might say, it sounds like your friend is worried about you, but the way she lets you know only makes you feel worse. Maybe we can try to help her to communicate to you her support in a more constructive and helpful way. So another piece that the BIC emphasizes is a sense of self-efficacy. So this is really a person's belief in their own abilities to successfully complete tasks. And it's really based on the feelings of self-confidence and control. And it's really at the heart of any decision to act. And there's evidence in the literature that patients with greater self-efficacy are more likely to take steps to make behavioral changes that can positively impact their health outcomes. One thing, though, to keep in mind is that you want to make sure that the patient understands that having greater self-efficacy doesn't mean that you do everything on your own. It just means that you're taking some initiative in support of your health. But if you know that to do that, you need to reach out to somebody else to help you achieve some of those goals, then you definitely want to do that. So it's not about doing it all on your own or sort of being immune to the need for anybody else's help. It's also important to emphasize to patients that self-efficacy is something that you aren't, necessarily born with. It's something that people can learn to develop over time. So here's an example. So a 30-year-old man is discharged after a suicide attempt by cutting. He's been struggling with chronic SI for years after losing several jobs and being out of work. He's also smoked for many years, but started using Nicorette gum, and he stopped smoking 5 years ago. And he mentions that he's thinking about joining a rock band because he really likes playing the guitar. And so here's a place where you might point out to the patient some aspects of self-efficacy and highlight to them actually ways in which they've already demonstrated that they're starting to build self-efficacy. So you might say to the patient, I can see it's been really challenging to manage the stressors of being out of work, but I'm really impressed that you're planning to join the rock band to help with the depression and loneliness. And we know that the first step towards recovery is believing that you can make positive changes. So here you're acknowledging the patient's current situation, you're affirming their motivation to change, and you're highlighting a key to self-efficacy, which is believing that one can change. And then you may also say, it's sort of similar to your smoking. I imagine it took some work on your part to think about how best to quit smoking, but then as you started to have greater confidence you could do it, you were able to make the change. So here you're helping the patient reflect on past achievements and helping them to see how this is a stepping stone or a bridge to moving forward towards the possibility of future successes. So we do have a self-efficacy handout that we developed that we think could be helpful as you're meeting with patients to share with them the handout and to remind them about the principles of self-efficacy. And we also want to reiterate that it's important, it can be helpful, I should say, to sometimes draw analogies. So for example, if a patient has diabetes, they may benefit from the analogy of the need to monitor their blood sugar and then alter their diet if they see that their blood sugar is headed in the wrong direction. And so it's similar with suicide risk. So if a patient starts to notice that their warning signs are getting worse, that's sort of a marker to tell them, I need to make some changes personally to try to address those warning signs before they get really out of control and something much worse happens to me. So now I'd like to move on to just provide you with some practical advice and review some of the session components when you're delivering the follow-up contacts. So first of all, before you start the long-term regular BIC follow-up contacts, it's really important to have access to the treatment manual. Initially, you may find that you need to read the manual script nearly verbatim to the patient, but hopefully as you become more familiar with the manual, you'll find that that's less necessary. You'll also notice that there are handouts on self-efficacy, and there's also a belongingness questionnaire, which will be administered at 3, 6, 12, and 18 months. And then you also have a copy of the patient's safety plan, which they should have filled out as part of the brief motivational session that already has occurred. And then Appendix 2 includes some facts about suicide that you may want to reinforce with the patient on these visits. So the contact visits, they should be led by trained volunteers from NGOs, individuals working with mental health, so maybe a mental health nurse, psychologist, social worker, community workers, medical students, or research assistants. There should be 9 visits that are scheduled at specific times after discharge over a period of 18 months. And then you want to use a modality as deemed appropriate by the local site. So that might be in-person, phone, video technology. Usually you'll find that the follow-up contact visits will last around 30 minutes. Depending on the patient's health status, these visits may be slightly longer or shorter. So if a patient is doing really well, maybe the visit is more like 15 minutes, but if the patient is really not doing well, then maybe the visit is more like 45 minutes. It's also really important that you have a backup supervisor system in place so that the trained volunteer has the necessary support that they need, especially if they encounter any problems during the contact visit. In terms of the session content, so you want to follow the specific order and structure that we've provided in the manual, which will start by setting the agenda for the patient. And here you'll be sharing with the patient who you are, asking the patient a little bit about themselves so you get to know each other. Make sure that the patient, again, understands what the purpose is of the follow-up contacts. Discuss the patient's overall well-being since the last contact, discuss their engagement in follow-up care, discuss their safety plan, administer the belongingness questionnaire, but only at visits 3 months, 6 months, 12 months, and 18 months. And then finally, wrap up the session with the patient. So the manual, you'll notice, includes 5 pages that cover the regular follow-up contacts by volunteers, and these pages should really be used to guide your conversation with the patient. And I like to use the analogy of cooking. So initially, right, when you're baking a new cake, the recipe might be completely new to you, and you'll really have to read it line by line. But eventually, after you've baked that cake several times, you'll get to the point where you're so familiar with all the steps that you really only need to use the actual recipe more as a reference, and you don't actually have to read it sort of line by line. So in terms of the session agenda and the review of well-being, it's important to keep in mind that the patient may not remember the study or the brief motivational intervention session. So it may be necessary, especially at that first contact, follow-up contact, to provide them with prompts to remind them of, that they're in the study and who they met with, and then remind them of the goals of the long-term regular BIC follow-up contacts. In assessing how the patient is doing overall since the last contact, it will be important to ask about suicidal behavior if there's evidence of a clear decline in health. And it will also be important to gather information in terms of how engaged the patient has been in follow-up care and any related interventions since discharge. Some patients you might find have been highly engaged, while other patients may show evidence of moderate, poor, or even no engagement. And so there is a decision tree in the conversation guide that will assist you in determining how to respond to each of these divergent situations. So the goals of the session for a highly engaged patient are really to affirm progress. And if they've made progress, it's really a good opportunity to also show them how they're demonstrating self-efficacy, that it's not just a random event, but how their progress really shows the things that they've done to improve their overall health and well-being. and you want to show that you're supporting their efforts to maintain engaged. If the person is showing moderate, poor, or no engagement, you want to really apply those motivational interviewing skills. You want to be listening for discrepancies in intended versus actual behaviors, help the patient identify pros and cons of current behaviors, explore ambivalence. You want to continue to work towards building self-efficacy and help the patient identify small, achievable goals that they can make to improve their engagement, and as necessary, remind them about effective suicide prevention strategies. So as part of the conversation with the patient, it's also important to ask them whether there's anything you can do to support their well-being. So for example, patients who are struggling may need your assistance in communicating to their provider that they're not doing well. And so you want to be listening to that and sort of seeing how you can help in that way. You also want to ask the patient to review their safety plan with you and consider whether there's a need to modify their safety plan based on your discussion with them today. And then remind the patient how the completion of the safety plan demonstrates self-efficacy and engagement. And if the patient tells you that they've misplaced their safety plan, then it would be really important to work with them to make a new one. So the belongingness questionnaire is in Appendix 8. It's a subscale of the Interpersonal Needs Questionnaire 15, and it asks specifically about their relationships with others. And we'd like the trained volunteers to administer this short questionnaire at 3 months, 6 months, 12 months, and 18 months. So finally, at the end of the session, you're going to want to wrap up with the patient and summarize sort of the key takeaways that came out of the discussion. It's also important to remind the patient about the additional long-term regular BIC follow-up contacts that they're going to receive. And we recommend that as part of the wrap-up, you incorporate the teach-back method to get a sense for what the patient took away from the session. And so, for example, if you as a staff member might say to the patient, I just shared with you the plans for further follow-up with our study team after discharge. Can you share with me what you heard? And so the patient might say, it sounds like the plan is that I'll have 7 more contacts with a volunteer in the next 12 months. So the teach-back method is just helpful because it's another way to make sure, did the patient really get what you were saying, and to clarify any potential misunderstandings or misconceptions that may have happened in delivering the intervention to the patient. So finally, I'd just like to end with just a couple of general tips and advice that we've learned from delivering the sessions. So first, it's really important in terms of becoming facile and delivering the session that you do a lot of practicing. We encourage you to do mock sessions with patients before the start of the study. You want to read through the manual multiple times. You want to focus on any areas of weakness, maybe seek out other colleagues who can support you in learning how to address some of those weaknesses that you might observe. Seek out any additional training before the study starts. So for example, if you feel that you don't know a lot about motivational interviewing, you might find it helpful to do separate training in motivational interviewing as well. And then you will have access to these videos that we are making so that you can review them at your leisure. In terms of preparing for this session, you want to make sure that you gather all the relevant materials before the start of the session. So like the manual, the patient safety plan, and the belongingness questionnaire. In terms of outreach activities, so it's possible that the patient may ask you to perform a specific task on their behalf to help them with engagement. And I would say that these activities sort of fall within one of the following categories. So you could have a situation where a patient is really in an acute crisis. And in that case, you want to be making sure that the patient is connected with the right medical personnel that can help them treat their symptoms and make sure that they're safe. In other cases, there may be some concerns around health or other needs, so maybe a medical issue or a concern or a wish to share with family. And so you want to engage with the patient to sort of understand to what degree the patient wants you to do these tasks and to what degree these are tasks that the patient can really do themselves and where it's another chance to help them learn self-efficacy and perhaps set it as a goal that they're going to do and then plan to share with you at your next contact with them. They may also ask you for other local resources to help them in the support of their health, and I would certainly encourage you to see whether you can identify those other resources. And maybe that's like group therapy, maybe it's some sort of recreational resource. So I would say those are the 3 outreach type activities that you might encounter. So I like this quote. So this is an African proverb. So it says that it really takes a village to raise a child. And I would say it also takes a host of dedicated professionals and volunteers to help with suicide prevention. And so I really appreciate your time and attention. And now I'm going to leave time for some questions. Thank you.